Let's talk about the evaluation, the diagnosis, and the treatment plan for lipedema. Lipedema is diagnosed primarily clinically by how it looks, the signs of lipedema. Typically, there's this column-like look with swelling that goes on in the legs, the arms, and many times some other places like the upper buttock area. There are lippy nodules that you feel, these little fibrotic nodules that is common with lipedema. So it's primarily really a clinical diagnosis of lipedema. There's no blood test for lipedema. There's no yet biopsy test for lipedema. And there's no genetic test yet for lipedema or DNA test for it. How I go about it in my practice is there's a consultation process. If a patient is not able to see me face-to-face, then I do what is called the photo phone consultation with the patient. They send in information in a questionnaire that we send to patients. They're instructed in terms of how to take photographs for me to evaluate, and then a consultation schedule with them on the phone where I review what they have written, I review their photographs, and then I ask them a lot of questions to fill in the gaps of knowledge. I explain my philosophy in terms of the approach to the lipedema patient, and we then get on in terms of a treatment plan in terms of what exactly should be done. To me, with lipedema surgery, it is definitely a very particular type of surgery. It has to be done in a very particular fashion, not only lymphatic sparing, but with many different areas of understanding. There's a lot more that needs to be done in terms of proper pre-care and post-care for lipedema patients. One of the philosophies I've always had, and I also apply this to lipedema patients, is that it's about creating proper balance and proportion to a patient's body. And in the lipedema patient, it pretty much is exactly that. We are targeting areas of disproportion. In most patients, this disproportion occurs in their extremities, their legs, and their arms. Usually it's not as much of a disproportion in their torso area. When they gain weight, it tends to go to those areas. It's the last areas that tend to come off, and that is what's targeted with liposuction surgery. So when I'm doing a consultation on a patient for lipedema, I'm coming up with a treatment plan in terms of what to do and how to target the patient, in what surgeries, where to target, the interval between surgeries for the patient. And to me, it's a very important thing to define exactly what the treatment plan is. So in terms of diagnosis of lipedema, who should be diagnosing it? It's at the present time, unfortunately, most doctors don't know about it. I'm heartened to hear that as time goes on, more and more doctors are beginning to understand and learn about lipedema and are actually able to diagnose it from the signs and the symptoms of lipedema, what it looks like and what the patient is feeling. A lot of patients still, many times in consultation, have not been diagnosed and send me photographs, and by the photographs and by the information that I see, I'm able to actually diagnose them with lipedema. But if you're coming from outside Los Angeles, I think it would be great to try to find a doctor who has heard of lipedema to begin with and understands it a little bit, at least in terms of the ability to diagnose it. But unfortunately, at the present time, there are not a lot of doctors around the United States that have extensive experience in lipedema diagnosis. So after I've reviewed the photographs and what the patient has provided me in the questionnaire, and I discuss with the patient and get more information, I form what's called a treatment plan. And what I mean by that is a surgical treatment plan in terms of what to target, the interval, in terms of the time between surgeries. So let me explain that a little bit. Typically, in your average lipedema patient that has their legs and arms affected, it usually is circumferential all the way around from the ankle area to the groin area. In those patients, the majority of them have the arms involved, at least the upper arms. So many of my treatment plans, I would say 80 to 90%, are about doing the surgery in two different surgeries and doing those areas completely. I do things in a circumferential fashion in most patients. I would say 90% of the time when I'm doing a person's legs, I'm doing them all the way around three-dimensionally, because that's the process of what's going on in lipedema. The fat has gone there through the lymphatics in a circumferential fashion. You have to follow that fat, and to get the best removal of the fat from a disease standpoint, as well as the best cosmetic result, I feel it's a good way of approaching it, or really a better way of approaching it circumferentially in most patients, except the very advanced patients with possibly later stage 3 or stage 4 lipedema or lipolymphedema. I usually group things as such. I group the calf and ankle area in its entirety all the way around, along with the upper arm area and many times the forearm, as one surgery. I will group the thigh area from the knee to the buttock area and many times the hip area and around the buttock area as a separate surgery. Each surgery is about a 4-hour surgery, 3.5 to 4-hour surgery. In most patients, I will do these surgeries a week apart, but in some patients that are larger or have a more complicated medical history, I will wait between 2 and many times 8 weeks between the surgeries.